Now let me ask you something from first week of development. First week of development, as I mentioned, what is totipotency? What is totipotency? And up to which stage this totipotency remains in the cell line after the cleavage division. After the zygote starts breaking by cleavage division, bringing the nucleocytoplasmic ratio to the normal by subsequent and rapid mitotic division within the zone of pellucida without much separation. That is the definition of cleavage. So they are giving rise to blastomeres, isn't it? Now at up to what cell stage this totipotency character remains, and what is totipotency? On which day zona pellucida disappears, on which day the fertilized egg enters the uterine cavity, on which day zona pellucida disappears, what is totipotency, and up to which cell division stage totipotency remains. On which day zona pellucida disappears, because if the zona pellucida doesn't disappear, the cells will not be able to attach with the uterine endothelium, facilitated by the pinopods, as I have told you. Then by which day zona pellucida disappears? I have mentioned it several times that on third day the fertilized ovum enters into the uterine cavity. Right? Cleavage division is on. Right? And at the stage of 16th stage, that is the morula. Alright? But the totipotent character, that means each of the dividing blastomeres can give rise to the whole of the fetus. Each of the blastomeres can give rise to whole of the fetus. That is a newer development. Except the membrane, that is the chorion or amnion, they cannot give rise to chorion or amnion. This character is known as totipotency, and it remains up to 8 cell stage. This remains up to 8 cell stage. What is more important, you have seen that there is an inner cell mass and an outer cell mass. Inner cell mass is called the embryoblast, alright, and outer the trophoblast. It is much interesting that the inner cell mass and the outer trophoblastic cells can interchange their position. Is it significant or not? That is, inner cell mass is coming to the trophoblastic layer. Our trophoblastic blastomere is going to be included in the inner cell mass. Whether it is important or not. This interchange is possible means what? They have the same potential. That's why the interchange is possible. Got my point? Anyway, today I will start with I have completed hip joint, the mid-carpal joint, right? Now start with the carpometacarpal joint. As I have told you, that is the first carpometacarpal joint is a separate joint cavity, not attached with the wrist joint, right? It is a separate joint cavity, right? And its synovial cavity doesn't include the other synovial cavities of the other disc joint components, alright? Now, you have seen, if you see your hand, you will find, you know the limb rotation? It was initially like this, right? And the pre-axial border become anterior and post-axial border become posterior. So, the cephalic vein is anterior, right? And in the lower limb, what happened? This rotation is medial. So, the great saphenous vein is medial. Pre-axial border is this rotated medially. So, the thumb is placed medially, the great toe is placed medially, and here, as this rotation is like this, so thumb is placed laterally. Got my point? Now, this thumb rotates in a plane which is more anterior to the plane of the other digits. এই যে পামের যে প্লেনটা রয়েছে, the plane of the palm, the thumb has rotated more anteriorly, and it has rotated, it is placed more anterior plane, right? And it has rotated up to 90 degree. It is rotated up to 90 degree. Got my point? Now, the articular surfaces, so it is a synovial saddle type of joint. Synovial, saddle or cellular type of thing. What is the meaning of saddle? Saddle কথাটার মানে কি? What is the meaning? The structure we put over a horse to ride the horse. The structure we put, that is a reciprocal convexo-concave surface. Reciprocal convexo-concave surface. Reciprocal means if it is convex, it will be concave, and if it is concave, this part will be, the other part will be convex. So, it is a reciprocal convexo-concave surface. That is the saddle joint. Got my point? Now, what are the ligaments attached to this? This comes, first carpometacarpal joint is asked in the viva, or it may come as a short note, not more than that, right? So, I will also summarize, I will tell you in brief that there will be capsular ligament, which is loose but fitting around the margin of the articular surfaces, right? Lateral ligaments on the lateral and medial aspect of the joint. What happens when the thumb rotates? Its dorsal surface becomes lateral. And its ventral surface becomes medial, isn't it? So look at this. Dorsal surface has become lateral and ventral surface has become medial, right? So its two collateral ligament will be actually on anterior and posterior aspect of the joint, isn't it? Not exactly on the lateral aspect of the joint, right? Connecting the peripheral margin of the first metacarpal as well as the distal end of the trapezium, right? Now, another ligament is that is the palmar and dorsal interosseous ligament. These both ligaments from the corresponding surface of the trapezium goes to the medial aspect of the base of the first metacarpal. From the corresponding aspect of the trapezium, they goes to the, that is laterally, alright. They goes to the base of the first metacarpal. Got my point? So, capsular ligament with synovial sheath, lateral ligament and interosseous, palmar and dorsal interosseous ligament. Done. Then about the, okay, there is the arterial supply is the radial artery, supply from the radial artery, nerve supply is from the medial nerve. Got my point? Now, what tendon will pass in this aspect? What tendons will lie in this aspect and on the posterior aspect? What are the tendons? Here you can find most important tendon is the flexor pollicis longa. There is flexor pollicis longa, long tendon. And the short muscles are the muscles of the thenar eminence. That is the flexor pollicis brevis, abductor pollicis brevis, and deep to it, in between and deep to it is the opponent's pollicis. Got my point? So this is flexor pollicis brevis, like this. This is abductor pollicis brevis, and deep to both and behind is the opponent's pollicis. Got my point? And deep to it, the long tendon of flexor pollicis longus is passing. Got my point? Alright. Now, on the posterior aspect, on the lateral aspect, you will find what? The lateral boundary of tendons of the lateral boundary of anatomical snub box, that is the abductor pollicis longus and extensor pollicis brevis, right? And on its medial aspect, that is on the posterior aspect, medial part, there will be extensor pollicis longa. What my point? This is the relation of the first carpometacarpal joint. Remember one thing also, that just distal to the flexor retinaculum of palm, just distal to the flexor retinaculum in this area, all right, at the lower part of your palm, front of the palm. This is the distal margin of the flexor retinaculum. From the distal margin of the retinaculum comes one recurrent branch of medial nerve. And it supplies the joint as well as it gives a cutaneous innervation of the area. Now, in case of first carpometacarpal joint dislocation, if it is an acute case, it is easy to manipulate and fix the joint under general anesthesia. Alright. But sometimes what happens, the doctors are unable to diagnose it as a case of first carpometacarpal joint dislocation, and a long time passes before it is recognized as a dislocation of the first carpometacarpal joint dislocation. Got my point? Now you need to open this joint. Tell me through your imagination, through what incision will you are going to open this joint cavity? From which aspect? And what will be the incision? You think over it, alright, and I will ask you again, alright. Now, let me tell about the movements of this joint. Remember, there is flexion, extension, adduction, abduction. Flexion, extension, adduction, abduction. Right? There is also circumduction and conjunct, medial and lateral rotation. What is conjunct rotation? What is conjunct rotation and what is adjunct rotation? Conjunct rotation means it is due to the ligamentous strain as well as the geometry of the articular surface. It is a passive action, not active action by any muscles or any group of muscles. Right? So, conjunct rotation is the passive movement by the ligamentous strain and the geometry of the articular surfaces. Right? And adjunct rotation is actively carried out by some muscles. This is the difference between conjunct rotation and adjunct rotation. In case of flexion and extension, you see flexion and extension. Right? This occurs along the plane of the palm. This is occurring at the plane of the palm. This is flexion, this is extension. Right? But what is the axis? Flexion and extension axis. This axis, anterior posterior axis. This flexion, extension. So this is the axis. This is the anterior posterior axis. Right? Now come to adduction and abduction. This is a transverse axis. Alright? Perpendicular to the plane of the, this is the plane, and this occurring perpendicular to the plane of the palm. Got my point? So nowadays in your OSPI section, there are a question is put to show movements of some joint, right? Like shoulder joint, flexion, extension, adduction, abduction, medial rotation, lateral rotation, right? Similarly, the ankle joint or the knee joint. This is given. You are asked to show, only show, not to describe. Right? So, and first carpometacarpal joint, that is the movement of the thumb, is a very important question for that living anatomy. This is called living anatomy, which we observe. Got my point? So, flexion and extension is parallel to the plane of the palm, adduction and abduction along a anteroposterior axis, and adduction and abduction is around a transverse axis, which is 90 degree, and this movement occurs at the 90 degree to the plane of the palm. Got my point? Now, what else? As you know, that the combination of flexion, so that is what this flexion, adduction, extension and abduction. This series starting from this order, starting from any point, completing the circle, is known as circumduction. Got my point? And if you see, during flexion, what is conjunct rotation? During flexion, you do the flexion. All right, you do the flexion. You will see that your first metacarpal is rotating medially, that is towards the ulnar side, and during extension, it is rotating laterally. So this is the conjunct medial and conjunct lateral rotation. Got my point? During flexion, the first metacarpal is moving medially, that is rotating medially, and in extension, this first metacarpal is rotating laterally. This is medial and lateral conjunct rotation. Got my point? So circumduction is done, conjunct movement is also done. Right? Now you try to understand what muscle will flex, what muscle will extend, what muscle will adduct, and what muscle will abduct. Right? Now, who are the flexors? Flexor pollicis longus and brevis. Right? Together with opponent's pollicis. What is the opponent's movement? Opponent's movement is the abduction, flexion, abduction, flexion, and followed by a swinging movement across the tip of the other digits. Alright, this is opponent's movement. What my point? First abduction, then flexion, then semi-flex fingertip touching the swinging movement of the thumb touching the fingertips. Right? Why this is needed? This is needed for gripping something precisely. Gripping something precisely. Right? Now, flexion is done by flexor pollicis longus, flexor pollicis brevis, as well as opponent pollicis. Now, extension is performed by extensor pollicis longus, right? Extensor pollicis longus and brevis. Now, adduction is by adductor pollicis. Adduction is by adductor pollicis, right? And abduction is by abductor pollicis longus and abductor pollicis brevis, both. It's not that much easy, right? It is not that much tough one. You will be able to remember if you can remember the thenar muscles and the back of the muscles on the tendons on the back of the, that is boundary, causing the boundary of the anatomical snap box. Right? Remember, this pincer grip, the strength of this pincer grip is increased by contraction of two muscles. Number one, adductor pollicis. Number two, flexor pollicis longus. Adductor pollicis, and flexor pollicis is longer. Got my point? This pincer group is strengthened by the contraction of the adductor pollicis and flexor pollicis is longer. Will you be able to remember this? Alright. Now come to the arterial supply, that is radial artery. Nerve supply is the median nerve. And applied importance, number one, dislocation of the carpometacarpal joint. Right? And in this connection, I would also like to mention the rheumatic node and the osteoarthritic node. Rheumatic node and osteoarthritic node, I will tell you later on. Alright. Where does the rheumatic nodule develop and where does the osteoarthritic nodule develop in the digits? Alright. As you know that the metacarpophalangeal joint are which type of joint? These are again like the ridge joint, that is their ellipsoid joint, synovial ellipsoid joint. Got my point? Another thing is, if you try to hold something large within your palm, this metacarpophalangeal joint not only flexes or extends, this also rotates. That is the speciality of the metacarpophalangeal joint. Right? Now go for the intermetacarpal joints. Intermetacarpal joints are plain synovial joints. These are plain synovial joints. As I have told you that the ridge joint is not communicated with the midcarpal joint, but the midcarpal joint is communicated with the metacarpophalangeal joint through two recesses between the bones, synovial communication to it, right? So the midcarpal joints are communicated with the metacarpophalangeal joint, right? Now about the interphalangeal joint, you must know that these are perfect hinge joints. This can flex and extend. No rotatory movement are possible here. Alright. And what is the criteria of a hinge joint? Criteria of a hinge joint is that its lateral ligament, lateral and medial, that is lateral and medial collateral ligament will be stronger. What my point? Lateral and medial collateral ligament will be stronger, right? Anterior part of the capsule is also strong, but the posterior part is deficient. Why deficient? Why deficient? Because there is the base of the dorsal digital expansion. What is dorsal digital expansion? you see, this is a tendon of extension digitorum. This is a tendon of, that is the extension tendon for the dorsum of the hand. That is the extension surface of the hand, right? And you see, at the base, at the head, at the base of the proximal phalanx, there is an arch-shaped formation. That is the base of this dorsal digital expansion. And what the fiber that moves along the dorsal surface of the proximal phalanx, that is the dorsal digital expansion. This is the base of the dorsal digital expansion, and this is the dorsal digital expansion, right? Dorsal digital expansion. There are two wing tendons. There are two wing tendons, right? This is palmar interosseous and this is dorsal interosseous. Interosseous. You know there are 4 palmar interosseous and 4 dorsal interosseous. Alright. This palmar and dorsal interosseous make the proximal wing tendon for this dorsal digital expansion. And this is from where from I am looking? From the posterior aspect? From the extension aspect? Where from I am looking into this? From the posterior aspect, that is the extension aspect? Yes or no? Right. Now, you see, if this is the deep transverse metacarpal ligament. This is called the deep transverse metacarpal ligament. Deep transverse metacarpal ligament. There is a superficial transverse metacarpal ligament also. Metacarpal ligament. So the proximal wing tendon, this is proximal wing tendon, PWT, formed by the palmar and dorsal interosseous tendon, right? These are attaching to this dorsal digital expansion. Got my point? And this is the lumbrical muscle. This is lumbrical muscle. Now this palmar and dorsal interosseous, if you see from the front, what will you see? These tendons are passing deep to the deep transverse metacarpal ligament. Got my point? If you look at this from the front, what will you see? These are crossing deep to the deep transverse metacarpal ligament, whereas lumbricals that come from the flexor digitorum profundus. The lumbricals that come from the flexor digitorum profundus tendon. There are 4 lumbricals, alright, that come from the flexor digitorum profundus. They are in front, that is superficial to the deep transverse metacarpal ligament. What's my point? And they are attached far away in the proximal phalanx. They are inserted far away from the proximal phalanx. Got my point? Now, what is the action of these lumbricals and interosseous? All of them flex the metacarpophalangeal joint. All of them flex the metacarpal phalangeal joint. Right? And extend this interphalangeal joint, where lumbrical being more in the anterior plane and more distal. So, it will pull much more than the interosseous. Yes or no? Which pull will be greater? Considering this joint, which pull will be greater? This nearest muscle action or the distal muscle action? Definitely this one. Alright. This is able to pull this much more than this proximal tendon. Right. So lumbricals are much more potent flexors of the metacarpophalangeal joint. Got my point? And due to the presence of this dorsal digital expansion, the dorsal part of the capsule is deficient. For what? For the interphalangeal joint. For the interphalangeal joint. and the dorsal digital expansion trifurcates. One joins at the base of the distal middle phalanx, and the other go to the base of the proximal phalanx. What my point? This is the structure of the extensor tendon. What my point? And how the dorsal digital expansion is formed. What my point? Alright. Now, so the lateral ligaments of a heel joint are strong. Anterior part of the capsule is also strong, but it is posteriorly deficient or weak due to the presence of this dorsal digital expansion. Done. What is mallet finger? What is avulsion fracture? I will tell you later on in course of the study. What you do not know is the structure of the basic structure of the hand. Without knowing the basic structure of the hand, you cannot embark on Palmar spaces. You cannot embark on the Palmar spaces because you do not know the basic structure. Right? Let me draw a simple diagram. As I draw, this is the palm of the hand, right? Where you can see at the base of the wrist, you can see the distal part of the palmaris longus tendon. Distal part of the palmaris longus tendon, right? And this tendon is fusing with the flexor retinaculum, fibers of the flexor retinaculum, and is continued over the palm as the palmar aponeurosis. It is continued over the palm as the palmar aponeurosis. It has a central triangular part, and on either side, this is a loose part. This part is loose part attached to this, but this part covering the hypothenar muscles as well as the thenar muscle. This is called medial and lateral septal part of the palmar aponeurosis over the thenar muscles and over the hypothenar muscle. Got my point? Proximally, it is triangular. It is the apex is here. The apex is towards the flexor retinaculum. All right, where it is actually a continuation of the palmaris longus tendon. Got my point? And this triangular part gives 4 digital slits. This gives 4 digital slits. 1, 2, 3, and 4 digital slits. All right. How can you see? How can you see? Forcibly extend your finger, and you will see there will be some prominence or oblique. There will be some prominence or oblique in between the digital slits. Can you see it? Forcibly extend it, you will see some prominence or oblique over the palmar aspect. Alright, these are the gap between this digital slits. Alright, these digital slits are dividing into a superficial band, superficial strata and the deep strata. Right? The superficial strata is blending with the dermis of the skin and with the superficial transverse metacarpal ligament. What is this? This is superficial transverse metacarpal ligament. What my point? These superficial fibers are blending with this, and the deep strata divides into 2. Deep strata divides into 2 and gets attached to the palmar interosseous ligament, deep transverse metacarpal ligament, and to the base of the proximal phalanges. Right? This deep strata is dividing into 2, right, and is getting attached to the palmar interosseous ligament, proximal part of the base of the proximal phalanx. What my point? Now, the skin of hand is very much interesting. The skin of hand is very much interesting, as we call the hand as a prehensile organ. That is, it can work precisely, and even as the sensory motor coordination, neuromuscular coordination is high degree, as well as the sensory, its representation into the sensory motor cortex is extended over an extensive area, right? So we can do all sorts of precision work through our hand, and due to this, even a property is endowed with our hand. What is that? If you close your hand, if you hold some known object or some unknown event, you can diagnose what kind of object it is. This is called stereognosis. This is possible due to abundant presence of Meissner's corpuscle. You know, this is a tactile receptor, Meissner's corpuscle, Pacinian corpuscle. All of these are tactile receptors. So there is abundant presence of this tactile receptor in the skin of the hand. Please come. Now, the skin is adherent to the palmar aponeurosis by thin fibrous strands. What we call? And in between there are fat loculi. Right? The skin is tightly adherent to the palmar aponeurosis. So the skin is almost immobile over the palm. Isn't it? Whether the skin of the palm is mobile? No. Why this is? Because if it would have been mobile, we would have grasped or gripped any object properly. Skin to chhod jaye. If the skin slips, we are not able to grip something tightly. What my point? So skin is tensely attached to the palmar aponeurosis through thin fibers which are called skin ligaments. Right? Now you can see in the hand, this is not that much important. There are 3 kinds of cleavages you can find in the palmar aspect of the hand. One is the flexor cleavage, right? This is the distal flexor cleave. This is the proximal cleave. This is the distal cleave over the digits. Alright. Now this flexor cleave doesn't correspond with the metatarsal head, that is the metacarpophalangeal joint. This distal palmar creep doesn't correspond with the metacarpal head or the metacarpophalangeal joint. If you turn it back, you will be understand that the metacarpophalangeal joint is at least 2 centimeters below the distal palmar creep. What my point? And again, in each digit, you will see 2 creases at the joint. The proximal one represents the joint line, not the distal one. The proximal one represents the joint line, not the distal one. What my point? This is distal, but the joint is proximal. 2 centimeters proximal. What my point? There are other lines which are called papillary ridges. What are those? If you see your terminal part of your digits, you will find there are some fine lines, prominent line, that is embossed, not engraved, right? These form either a hole or an arc or a loop, right? And along this holes or arcs or loops, there are pores of the sweat gland. What my point? So when we touch something, this imprint can be reproduced, and the science is known as dactylography. What my point? And there are some other line, that is the Langer's line or cleavage line, that is due to the disposition of the collagen fibers across the skin. It is transverse in case of dorsal of the hand, and it is vertical in case of the palm of the hand. What my point? It is transverse in case of the dorsal of the hand, and it is vertical in case of the palm of the hand. So 3 types of lines I have described along with the papillary ridges that forms a basis of dermatoglyphs or fingerprint technology. What my point? Now, if you lift up this palmar aponeurosis, right? You just cut it from here and reflect it distally. What will you find? You will find layers. At the first layer, you will find the superficial palmar arch. And the dorsal digital branches of median nerve and the branches from the superficial palmar arch. What my point? And the deep to it, you will find the long flexor tendon. Deep to which lies the deep palmar arch. Along with the long flexor tendon, you will find the lumbricals. What my point? Now, deep to the deep part, you will get another layer of muscle. There are palmar and dorsal interosseous, as well as the adductor pollicis. This is the basic idea of the hand, right? Skin adherent to the palmar aponeurosis by thin skin ligaments, and with fat locule in between. Remove the skin, you will find the palmar aponeurosis central part triangular, and the lateral part, medial and lateral part covering the thenar muscles and hypothenar muscles. This triangular part divides into 4 slits going to the digits. It has a superficial strata and a deep strata. Superficial strata goes to blend with the superficial transverse metacarpal ligament. What my point? And to the base of the proximal phalanx. And the deep strata goes to blend with the palmar interosseous ligament as well as the deep transverse metacarpal ligament. Right? The palmar and dorsal interosseous are deep to this deep transverse metacarpal ligament. Right? Whereas lumbricals are superficial to this deep transverse metacarpal ligament. What my point? Now, if you find how to see the gap between the slips, if you forcibly extend your finger, then you will see there are in between the gap of these digital slips, the soft tissue bulges out. What my point? Now, in between the gap, you will be able to see the digital. Here, you will be able to see the digital vessels and digital nerves. Here we will see the digital vessels and digital nerves. Going to the digits. What my point? Now, remember one thing, should I erase this part? Flexor retinaculum. Over the flexor retinaculum, you will see this is the radial artery. This is the radial artery, and this is its superficial palmar cutaneous branch. Right? This is the median nerve. This is its superficial palmar cutaneous branch of median nerve. This is ulnar artery. This is its superficial palmar cutaneous branch. This is ulnar nerve. This is its superficial division, and this is the deep branch. Hook of Hammett, this is crest of trapezium, this is piriformis, this is tubercle of scaphoid. This outline the boundary of flexor retinaculum. What my point? Now, if you open this up, this part is removed. Cut and deflected distal. Then you will find these are the four tendons of flexor digitorum profundus. These are the four tendons of flexor digitorum profundus. Oh, in the last day, at the beginning, I said that the intermediate compartment by flexor digitorum superficialis. At the end, also I said that the intermediate compartment is done by the flexor digitorum superficialis. But in between, I have severally uttered flexor digitorum profundus and flexor pollicis longus. That was due to hurry. All right. Remember, the flexor digitorum superficialis makes the intermediate component. All right. Now, this digital tendon for both the flexor digitorum superficialis as well as the flexor digitorum profundus is lined with a synovial sheath and a fibrous flexor sheath. This digital tendon of profundus or superficialis or flexor pollicis longus all are lined with a digital synovial sheath, and in front of it there is a fibrous flexor sheath. What my point? Now, this digital tendon of flexor profundus is deficient. Synovial sheath is deficient at its middle part, and from that denuded part, the lumbricus comes to takes the origin. This takes the lumbricals takes the origin. All right. This takes the origin. Where from? From the flexor profunda at the denudate part where there is no flexor synovial sheath. Because the flexor synovial sheath goes along with the lumbrical to form the lumbrical canals. To form the lumbrical canal like this. From this tendon, this is going like this, forming the lumbrical canals. This is going like this. So this area is devoid of the digital synovial sheath. Got my point? Lumbricals is R in relation to movement of the metacarpophalangeal joint and interphalangeal joint, right? And remember, lumbricals are called link muscle. These are wall-like muscles coming from the tendons of the flexor digitorum profunda, right? And is attached to the distal joint tendon to the dorsal digital expansor. What my point? And this is ventral to the deep transverse metacarpal ligament. This is ventral to the, that is anterior to the deep transverse metacarpal ligament. Whereas the palmar and dorsal interosseous are deep to the, that is behind to the deep transverse metacarpal ligament. Is it understood? Is it clear to you? Is it clear to you? And lumbricals and interosseous. Both are flexors of metacarpophalangeal joint and they are extensions of interphalangeal joint. Whereas the lumbrical is a more potent flexor of the joint. Done? Alright. Now, if you open up knock me when it is close to 10 or 15 minutes to 11. Alright, I will give you some rest and then I will continue. Okay. This is the flexor retinaculum which is attached to the crest of the trapezium, tubercle of the scaphoid, hook of Hammett and the pisiform bone. Right? It has a superficial slit and the deep. If I open up this flexor retinaculum, what I will find? Alright. Showing the proximal part, that is the hook of habit at the crest of trapezium. Right. And in between the two slits, there is the flexor pollicis longus tendon. Right. And the synovial sheath that is enclosing both the flexor digitorum profundus tendon. This is flexor digitorum profundus tendon, FDP, and this is flexor digitorum superficialis tendon. And you can see that the parietal layer of this flexor sheath is coming to enclose this, reflecting back, and then again enclosing this other part of the tendon. This is called ulnar bursa. This is called ulnar bursa, right? And the synovial sheath that cover the flexor pollicis longus is called the radial bursa. The synovial sheath that covers the flexor pollicis longus is the radial bursa, right? This ulnar bursa start 2.5 ps, 2.5 centimeter proximal to the wrist joint. Then it encloses the flexor tendon, and its lateral, its medial part is continued to the little finger. This is like this. Its medial part is continued in the little finger, but the other part is up to the mid of the palm, and there is the continuation of the radial parts separated. This is separated. So the synovial sheath around the flexor pollicis longus is continued with the digital synovial sheath of the thumb. The synovial sheath that is continued to the thumb is the radial bursa, right? And the medial part that goes to up to the little finger, that is the extension of the ulnar bursa. This whole thing is ulnar bursa except the synovial sheath that is covering the flexor pollicis longus, which is the radial bursa going to the digital synovial sheath of the thumb. Got my point? Now this radial bursa and ulnar bursa sometimes can communicate behind the flexor retinaculum, communicating infection from the little hand to the thumb, right? And we need to drain this. How we are going to drain this? That is clinically important. How we are going to drain this? We put two transverse incisions, one near the distal digital fifth, one at the base, and open up this canal, right? And drain the pus, secretion or whatever. Got my point? We put two incisions at the distal fifth, digital fifth, and at the base to open up this canal. Got my point? There is another point. Both for radial bursa and ulnar bursa can communicate within the joint, and this continuation comes in between the proximal to the flexor retinaculum to enter into the space of perona between the superficial and deep group of muscles of the forearm. Between the superficial and deep group of muscles of forearm. That I have talked, that is, it is up to 2.5 centimeter proximal. It may be up to 7.5 centimeter to the proximal, and pus can enter and move upward up to that limit. This is the space between the superficial and deep group of muscles of forearm. What's my point? Now, let us talk about the space just give to the skin of over the terminal phalanx. It is called Pulp space. It is called Pulp space. Right? You can see the Pulp space is traversed by fibrous strands to the bone, and in between there are 5 fat loculi. Alright, and these strands are also holding the vessels and nerves in the digits. This is the nail bed, this is the nail, this is the nail bed, and this is the skin of the digit. Right, and you can see this is the fibrous flexor sheath. Don't misunderstand this. Which one is fibrous flexor sheath and what is digital synovial sheath? This is the fibrous flexor sheath. Fibrous flexor sheath. And this one is the digital synovial sheath. This is digital synovial sheath. Right? This is the phalangeal bone. This is flexor Dupuytren profundus tendon. This is flexor Dupuytren superficialis tendon. Right? These are enclosing both. There is a parietal layer and the visceral layer. Alright? Where they are continuous. And these are digital vessels and nerves. Got my point? When this area gets infected, when the pulp space area is infected, it is tremendously painful. It is tremendously painful, and there is excruciating throbbing pain at our tip of the fingers. That is the last part of our digits, right? Because there is fibrous septum, the pus cannot burst out. So in a closed space, the pus tries to burst out, and that is why there is a throbbing pain, excruciating throbbing pain. This condition is known as the pulp space infection of the digits or the Whitlow, W-H-I-T-L-O-W, Whitlow. To open this condition, local anesthesia sometimes fails to alleviate the pain, right? So sometimes we need a light mode of general anesthesia, and we open the pulp space through lateral incisions. Alright, through lateral incisions. What my point? Now, up to this point, you see this visceral layer and the parietal layer is continuous at some point. TSMC. When in the embryonic period, this was continued with the periosteum of this bone, and this space conveyed the digital vessels and nerve. This space initially conveyed the digital vessels and nerve. Here. This part is called mesotendon. This part is called mesotendon, which due to excursion of the finger, which was vanished. What my point? This mesotendon got vanished when the finger movements and excursion of the fingers was ready and was performing. What my point? So this is the pulp space infection. The last part remains with the deep Palmar space. What much time is left? 12:25. So why didn't you give me an alarm by 1 hour? বললাম তো আমি। Okay. So you got the understanding of the carpal tunnel. This is the carpal tunnel. You got the understanding of the carpal tunnel. That is medial nerve is plastered to its upper layer. That is the Palmar Aponeurosis, and there are 4 tendons of flexor Dupuytren profundus and as well as flexor Dupuytren superficialis, right? And there is a tendon of the flexor pollicis longus. Flexor carpal radialis also just around an outside slit. All right. Now, if there is any infection, pus formation, accumulation of exudate, this will compress the medial duct, and there will be the carpal tunnel syndrome. There will be wasting of the thenar muscles as well as pain and tingling over the distribution of the medial nerve. What my point? This is carpal tunnel syndrome. This may be due to osteoarthritis, thickening of the muscle tendons, swelling and thickening of the muscle tendon, as well as lunate dislocation can also give rise to carpal tunnel syndrome. Lunate dislocation can also give rise to carpal tunnel syndrome. And in infected cases, lunate undergoes either an avascular necrosis or osteomalacia, which is known as Kiel-Brooke disease. Kiel-Brooke disease. Let me of lunate. The pronunciation is Kiel-Brooke. Alright. There is two armlots. This is Kiel-Brooke disease. Yes. Due to dislocation of the volar displacement of the lunate. Yes. All. So, should I erase this part? Erase the right part.
It all done. Final TBS.
Anyway, the diagram looks a little clumsy due to absence of marking, proper marking to this markers. Alright. You see, this is the thenar evidence, this part. Alright. This is the hypothenar evidence, and in between this is the central part of palmar aponeurosis. Got my point? This is thenar evidence, bulging of the thenar evidence. That is the muscles with flexor pollicis brevis, abductor pollicis brevis, and the Aponeurosis pollicis. This is the hypothenar evidence with the flexor digiti minimi, abductor digiti minimi, and Aponeurosis digiti minimi. Right. In between these two, there is abductor and flexor. The deep to it is the Aponeurosis digiti minimi, or here the Aponeurosis pollicis. Right. You see, here I have drawn that the deep branch of ulnar nerve and the ulnar artery is entering just deep to the hook of the hamate. Just deep to the hook of the hamate, deep branch of ulnar artery and ulnar nerve. And this part of the tunnel is known as Dupuytren's canal. Guyon's. This is known as Dupuytren's canal. Right. And now you can see penetrating the Aponeurosis pollicis. This is deep branch is coming to supply all the dorsal and palmar interossei. All the dorsal and palmar interossei. Together with the first and second lumbricals. Right. Third and fourth is supplied by the median nerve. So all the palmar and dorsal interossei are supplied by the deep branch of ulnar nerve, as well as the first and second lumbricals are supplied by the ulnar nerve. Alright. Now you can see that below this fascia, this medial septum, that is a part of the palmar aponeurosis. The lateral septum is also a part of the palmar aponeurosis. Alright. This is continued back as the deep fascia of the dorsum of the hand. Deep fascia of the dorsum of the hand. What my point? And there lies the extensor tendon. And deep to the extensor tendon, this space is called subaponeurotic space, and beyond the tendon, this is the subcutaneous space of the dorsum. What my point? Now you see there is a thin division between this within the carpal tunnel that separates the medialmost tendons of both flexor profundus as well as the flexor superficial. Right? But this tendon, this separation is very thick. After the palmar interosseous fascia, which is a dense fascia. Alright. This is dividing this space below is into the thenar space and the mid-palmar space. The thenar space and the mid-palmar space. Got my point? Where is what? This palmar interosseous fossa is a thick one, right? And the space between below it is divided into midpalmar space and the thenar space. Alright. If you see in this diagram, this is thenar space, this is midpalmar space. What we call, and if you want to drain this, you have to slip from the dorsal. Alright, waist space. You have to open the waist space, slip the waist space, and then you can drain this thenar space and the midpalmar space. If there is an infection. One thing last is that there could be infection of the palmar aponeurosis also. There could be infection of the palmar aponeurosis also. This causes a phenomenon which is known as Dupuytren contraction. D-U-P-U-Y Dupuytren. T-R-E-N' Dupuytren contraction. Whereby mostly the ring finger gets stretched, followed by the little finger. Alright, but this other three fingers remains free. This position is also named as Benedictine hand. This is also called Benedictine hand of prophecy. This is also known as Benedictine hand of prophecy, which also occurs due to paralysis of the lubricants. Alright, for these two fingers. What we call? So this contracture is known as the Dupuytren contracture, which is to be differentiated from the ulnar clawhead. Ulnar clawhead is also like this, yes or no? So it is to be differentiated that it is not a Dupuytren contracture, but this is not an ulnar palsy, but is a Dupuytren contracture. What my point? Let me finish today. Alright, don't want to tell anything else. You should know how to open the spaces for drainage. What are the where the spaces are and how it is formed, how far it is extended proximally and distally, right? And the sources of infection that can infect this and cause loss, pain, etc. And you need to open this space. Right. So surgical incision opening these spaces is the main applied importance of the clinical importance. And the foremost importance is what? You have to diagnose it. Isn't it? You have to diagnose it. Is that it is a Palmar space infection or the Thenar or Midpalmar space infection or the infection of the ulnar bursa or the radial bursa. What we call? As I told you, the radial bursa and ulnar bursa can communicate deep to the flexor reticulum within the carpal tunnel, right? And both are extended 2.5 cm proximal to the region, right? That is proximal border of the flexor reticulum, right? This may even pass in between the superficial and deep groove of the muscles of the front up to 7.5 cm, which is known as this space between the superficial and deep groove of forearm muscle is known as the space of peroneum, which might extend up to 7.5 cm over the forearm. Alright, now I know that this much. Oh, remember one thing that if the tendons within the flexor tendon, that is the flexor profundus and superficial. As I told you, the superficial splits and through this the profundus tendon passes up to the base of the proximal canal, and the superficial tendon is attached on either side of the middle canal. Right? Now, I have not said the vehicular breathing. Alright, just simple thing. These are small fibrous bands connecting the tendon with the bones. Alright, there are 2 vincula previa and 3 vincula longa. Alright, I will draw one picture later on. It's not a problem. Right? Now, what the pulse space infection is known as the whip, which is tremendously painful, and we have to open it through lateral incision. Okay? The ulnar bursa, infection of the ulnar bursa, you have to put 2 incisions at the distal crease and one at the base to open from both sides. Right? For the ulnar bursa and radial bursa infection. Right? And I told you that for the Thenar and Midpalmar space infection, you have to go around the weight space. Alright, you have to go around the weight space. And the lumen distribution, volar, that is power distribution of lumen, can compress the median nerve and give rise to the carpal tunnel syndrome, where there is inability to wriggle. কাপড় বদলাতে পারে না, নিংড়াতে পারে না, ঠিক আছে? এসে বলবে যে আমি কাপড়ের উপরে ধরতে পারি না, the form of the covering of some can, etc. I cannot open it. Alright, this is the typical complaint of a lady, usually related with some sort of thyroid problem. Alright, and there is swelling of the tendons, and there is compression of the median, and there is wasting and weakness of the thenar muscles, along with the pain, tingling, numbness over the median nerve distribution area. Right? There is, if you ask her to flex, alright, flex, there will be increase in the pain and tingling. This is called TNL sign, TINEL sign. So if you can pass some of the nerve, this will also give the pain and tingling over the median nerve distribution over the thenar area. Right? One thing more is that there is another disease about the tendon, which is known as dequerment stenogenic tenosynovitis. Dequerment stenogenic tenosynovitis. Write down the term, I will tell you. Alright, this is a stenogenic tenosynovitis of the tendon. Alright, and there is another thing is ganglion. There is a synovial sheath of the tendon, collects some fluid and bulges. It is most commonly on the dorsum of the huge joint. That is called ganglion. This is also due to tubercular diathesis. I will tell you this thing later on. Alright, let me conclude here. Thank you for patient listening. Okay, alright.